This is a conversation with Dr. Joshua Brown, Assistant Professor of Psychiatry, Harvard Medical School. In this interview, Josh tells us what key things clinicians should know before implementing TMS. He delves into the working mechanisms of TMS treatment at the neuroplastic level and explains why he believes TMS will soon be the gold standard treatment for depression in the near future, paving the way for its use in other disorders that will quickly follow. I'm sure you'll enjoy listening to our conversation. Hi, and thanks for joining me. I'm Dr. Trevor Brown, Academy Manager for Neurocare Group. So thanks again to Neurocare for sponsoring this and allowing me to speak to Dr. Joshua Brown, who is Assistant Professor of Psychiatry at Harvard Medical School. Joshua, how are you going?
I'm going well, mate. How are you? Good day.
Good. Straight away, the Australian colloquialism. Love it. Thank you very much. It's we're so happy to have you join us today, Joshua, and in this interesting time for the field of TMS. In fact, I think I'll just straight away off the bat just mention that the passing of Dr. Nolan Williams, of course, and just recognizing that he did come onto the show a few years ago, and I interviewed him. Very sad, the whole field. Joshua, did you know Nolan at all? Get to work with him?
Yeah, I knew Nolan, I would say, fairly decently, actually. So I did a neurology and psychiatry program, a combined program at MUSC for residency, Medical University of South Carolina. Nolan actually was leaving that same program at the same time that I came in. And when I started, there's only like 4 of these in the country. And so when I identified this, I contacted the program director, and he's like, before he pretty much said anything, he's like, let me put you in contact with our chief resident, Nolan. And so Nolan and I talked for, I would, as I remember, maybe like an hour and a half or something on like the first call. And then we had a series of calls before I actually came out and interviewed or did anything else. And, one of the reasons that I went there was Nolan had actually like kind of trailblazed a way where and I had a lot of similar interests. I wanted to get into brain stimulation. I was aware of Mark George being there, the combined program being there. And, so we had a lot of talks about those things. And Nolan had, in kind of the Nolan way, figured out how to not only do the already existing neurology psychiatry program, but leverage, like bring in in 25 funded fellowships. So this is something that MUSC had, and then residents can join into that. And so you basically get a baked in research fellowship. And then on top of that, an interventional psychiatry track, which had been put in there. And so as I calculated, it's like 13 years of training if you were to kind of do it sequentially and separately, packed into 6 years. So essentially I saw what he did, and that was, like, that's what I want to do. Kind of went in there. And then, we essentially, Nolan was pretty good at staying in touch kind of over time and over the years. And I've heard from a lot of people that he kind of had a similar mentorship kind of role with things. I was able to actually, Mark George held a ceremony, like a memorial service for him, and was actually able to be there in Charleston and, heard remarks from him and from friends of his childhood and things like that. And so along with many of the people that he, touched, like working closely with, without question, it's regardless of what, anyone's opinion was like of Nolan, he certainly, I don't think it's arguable that he left a huge sort of hole or gap in the field. And, hopefully kind of brings our thinking and our attention to some of the things that are easy to forget as we get very much caught up in all the things we're trying to do, which are important. But, it's so important to still like take care of our own health, and also to be able to reach out and, ask others when help is needed. And I think that would have been hard to do. But, I think all of us really wish that he would have. And that's one thing that's kind of become even more clear than I would have expected, is so many people really just wish, and myself included, that, I had this thought, and I'm not the closest person to Nolan, he's much closer to others, but I still feel like, oh, if I could have, talked to him, I feel like I could have maybe said something or whatever. I can't imagine the way that a lot of others feel, and kind of having the chance to hear from Mark and his thoughts on that. There's what I think is I've actually told this story a number of times because I think it's really funny. And then the story turned when this happened, and I was kind of thinking about it, and I didn't get a chance to say it in the memorial service, but I sort of took on a new meaning after this happened. He and I were uh, at Aspen skiing, snowboarding, and we were meeting up, and we met like up at the top of this ridge to start. And I didn't know how he was, and so I pointed down this hill. And I've been told by Sean Siddiqui that this I shouldn't tell this story because it's like an indirect boast. So I'll just say off the bat, like I'm a good skier. Not trying to beat around that or anything, but there's this like good pitch, decent mogul field kind of a thing. And I'm like, what do you think about that? And he's like, yeah, let's do it. I'm like, great. Like I didn't get a chance to assess his snowboard or anything, but kind of went down it. And, he was kind of making his way down kind of slowly. And so we kind of realized at the bottom, is like, yeah, we'll avoid that kind of stuff in the future. And then that was it. And we kind of went and did other things like, the rest of the day. And then like a year, the funny part of the story is like a year later, he's describing us, and he's Sean and Nolan and I were in Boston, and he's describing, he's like, yeah, he took me down this hill like this. And I'm like, what are you talking about? Like, you looked at it. You could have just said, no, I don't want to do it. And he's like, what am I going to say? I'm scared, And so I thought it was like, it just like, it was so funny just because it kind of struck me as like a funny part of Nolan. And the thing that kind of switched for me is that I was then thinking about it a little bit after, and it's like a double-edged sword. It's like, that's part of what made Nolan is that not necessarily that he was fearless, but he had the courage to like push through the fear. And, he's got a lot of experiences through his life. I think that as I sort of learned, and learning from others, that kind of led to that, like the Taekwondo and kite surfing and things that he overcame, in his own childhood and his own life. And so that's part of what allowed him to kind of push forward and do the things that he did, and, be a real trailblazer, because he was able to sort of swallow and overcome those fears and just go for it. The flip side of it is that, it almost kind of gives a little bit of insight into, maybe the person that didn't ask for help, right? And that didn't, say, okay, I need to step back, or I need to take a break. And I remember him some years ago saying, he's like, yeah, this pace is, it's too much. He's like, I'm gonna have to slow it down. And, once you kind of start in that process, like it's almost impossible to slow it down. It's got so much inertia. And the more that he did, the more that people would reach out and bring him in and have him involved with things. And so yeah, I mean, I'm glad you brought it up, just because I think it's such it's central to what we're doing, really, not only just him as a figure, but his work that we can honor, and then also him in the way that we can, even the way that he died, and the way that we can essentially honor him by, taking that time ourselves and to kind of, learn from that lesson, that we can reach out, that we can slow down, that we can look for help. So hey, thanks for raising. It's certainly not something to avoid, and perhaps he can kind of, help us learn in this way as well.
Yeah, thanks, Joshua. And look, thanks for sharing that. It's a great insight into Nolan and what we can appreciate from his life, and learn from it, and yeah, help others, of course. So thanks very much. And yeah, it was great to have Nolan on to interview him here in Neurocare. And we won't, we won't ever forget, the hole he's left, like you said, that he was the founder of the Saint Protocol from Stanford University, and that will remain for a long time a large piece of, an ITBS, a large piece of TMS care. And our thoughts go out to his wife and kids, of course. Now, Josh, today we're going to get to know a little bit about you, about yourself. And you've also already mentioned you're a good skier. So looking forward to hearing a bit more about that. But we're going to just talk a little bit about your background, current things you're working on in the field of TMS. But particularly, we're going to focus on the key things that clinicians should know about before implementing TMS regarding our current understanding of how TMS actually works, the working mechanisms, also how sleep improvement in TMS patients can change outcomes, because knowing these things can help us explain things better to patients, help us deliver TMS in a way so that we can optimize our treatment and get better outcomes. But first of all, before we get into that, tell me a little bit about yourself, your sporting acumen, where you were born and raised, education, that sort of thing, Josh.
Sure. So yeah, about me, I guess, born in Salt Lake City, Utah, grew up in, mostly around that area, graduated from the University of Utah in psychology, actually was planning on being a family marriage therapist. And then I was in a cognitive psychology class, learned about the physiology of vision and actually mechanistically how it worked. And that was, a very clear, pivotal moment for me where sitting before the next class, it was like, boom, I knew that I was going to change the direction that I was headed. And so that was a guiding decision for doing, I then did a MD PhD combined degree at the Medical College of Wisconsin. So that was kind of a pivotal part of that decision. And then that also was a similar driving force in deciding to do both neurology and psychiatry to understand the brain. And so that those were kind of the motivating forces behind that. I mentioned that was at MUSC. And then from there, I went to Brown. I was there for 2.5 years. And then I've been at Harvard Medical School and McLean Hospital for the last 3 years. And, as far as skiing acumen, I played a lot of sports actually. So pretty much any sport I'm interested in and I enjoy doing. Skiing, I had good access to it growing up in Utah, and dad, they kind of did part-time ski instructing, so we get a season pass, and you can't really beat that. And wasn't really good at water sports in Utah. We don't have a lot of that. And then when I went to MUSC, actually through Nolan taught Mark George how to kite surf, who then had a little group of trainees and myself included, and we had like a Tuesday evening kite surfing group. So we'd go out, learn to kite surf for a little bit and then have pizza and stuff. So that started a new love for me as well. So now kite surfing sort of rivals up there with skiing is the favorite, but I like, biking, triathlons, mountain biking, rock climbing, kind of all the recreations, enjoy that a lot. It's for me, it's kind of how I, stay sane. And, another kind of big part of me is, my family, which I don't know if it helps me to stay sane or if it drives me towards insanity, but I have 4 kids. They're on the older side now, teenage years. So, it's fun and also a little bit of, I probably have lost some hair, due to those guys but great supportive wife. And so that's me.
All right, thanks, great for letting us know a little bit about you, Josh, and your sporting acumen. That's very cool. I've actually never skied in my life, so
Oh,
I don't have access to that here in Melbourne, and spent my time doing other sports, of course, which kept me indoors. But yeah, I won't go skiing downhill with you, that's for sure. All right, now that we've got to know you, Josh, let's have it's interesting because when we read your research, it's very complicated, right? There's a lot of basic neuroscience in there, a lot of neuroplasticity, a lot of AMPA receptors and this and that, and the really basic neuroscience of mechanisms, BDNF, all sorts of things. So all sorts of coil angles and magnetic fields, E field representations. So you do get into some very, very complicated neuroscience. So let's try to keep it as understandable as possible and lead people through, I guess, what's important to the clinician. And so that leads us to your papers in neuroplasticity. You've tried to make it a little bit more basic for us. A great paper is called Synaptic Plasticity 101, the story of the AMPA receptor for brain stimulation practitioner, the role of BDNF, etc., chronic caffeine consumption, and how that curbs RTMS plasticity. You've done a lot in the area of neuroplasticity. Why do you think that's relevant to the TMS practitioner? Do you think that helps us provide care in a better way and make decisions and explain things to our patients?
The short answer is yes. I do think that neuroplasticity is important. As a psychiatrist, and even within neurology, but I would say I would say especially with psychiatry, I found myself just in a general clinic and inpatient units and so forth. I feel like it's essential to understand it, and like people use that term and they throw it around all the time. And it was actually in residency that I wrote that paper, and it was in talking with a number of people. I almost universally would hear something like, um, yeah, like I know, about, or I know what synaptic plasticity is, or I'm kind of vaguely familiar with it, but I don't really understand like what it's talking about, or like what's actually involved with it, or even like how it relates to things. The importance of it, at the most basic level, synaptic plasticity has now been well established as the cellular basis of learning and memory. And learning memory, not just like, can I memorize something, but learning memory is in, the CBT that we're doing, and all the types of therapy, even the, sports training, and even traumatic memories, right? Like synaptic plasticity is in both directions, and not saying that it's like a simple process, and it involves networks and circuits that are imposing on one another, which becomes even more complicated in the animal models that I studied. So that was the motivation actually for that article that you referenced, was trying to explain in a way that, in my mind, it kind of boils it down to kind of the essential components, and to be able to actually understand, like, okay, how does this actually play out? And so that was the intention there. So I use it a lot from even just a kind of a counseling standpoint, at a general patient level, and um, understanding, okay, when we, to bring up Nolan, like he, talked about kind of the space theory. When he would give talks about Saint, he would describe, the 50-minute interval as if we're studying flashcards, where we don't just do it straight through the day. Similar, like if we're working out, we don't necessarily just work out for 24 hours straight and then take a few months off or something. Like we have it broken apart, because that's one of the, it's on the basis of learning and memory. The prior, there's decades of prior research on synaptic plasticity. So that's what I studied. And then it kind of became a big part of my current career. Sort of always knew that I wanted to move from the basic, foundational science, neuroscience, with animal models, and to kind of move into like translational research with humans. And when I started to learn more about brain stimulation, first with deep brain stimulation, and then later learned about TMS, that, this was like a perfect application for that. And that was part of why I was like, okay, I knew that in residency, for example, I wanted to pursue this, find some place that was strong in brain stimulation. And, of course, no place really better than MUSC for that. So that was you know, synaptic plasticity was sort of a part of that background. And then um, I remember also sitting with Mark in one of the kind of the earlier parts of residency. And I was thinking about, okay, what am I going to do for this research track, that I had mentioned? And I still remember him pointing out, he asked about what I did and what I studied. And I kind of explained, how we learned like how LTP, long-term potentiation, works, and how LTD, long-term depression, works, and kind of what's involved in that. And he's like, John Rothwell just gave this talk. John Rothwell, for any that don't know, is from England, and he's kind of a sort of a father of TMS neurophysiology, I would say, and knows kind of among the most, I'd say, in the world about TMS mechanisms. And so he was giving a talk at the brain stimulation meeting in Barcelona in 2017, and said, we've been saying that TMS works through LTP, synaptic plasticity. LTP is just one of the most commonly studied forms of synaptic plasticity. Saying we think that it works through this, but we have like 2 studies with very small studies that really have looked at this at all, and you can only look at a couple components of it in that way. And so the point is that we really don't know a lot about it. And at that point, I hadn't really started getting into the TMS literature at all. And so I was like, you can imagine my excitement that the thing that I knew well from before, and the thing that I was wanting to get into, like there's this convergence point. And so that was what led to the first study that I did, was combining D-cycloserine and NMDA receptor partial agonist. This had been used in a couple studies before. It had been used in a TDCS study. The reason the NMDA receptor is important is because it's one of these critical rate limiting steps in the synaptic plasticity pathway. It's really the regulator for, do we let plasticity happen or do we not? Is it just a synaptic event? Animal stuff that by enhancing the activity of NMDA receptor, which and technically it keeps open longer, and combining that with TMS could enhance the effects of it. And also, what was really kind of centrally important to me is that it would test the mechanism by seeing if it's sufficient, if D-cycloserine was sufficient to enhance TMS effects. When, like in basic science experiments, you want to see if something is necessary for that thing to happen. So, if we're going to look and see, okay, does TMS work through LTP? Is NMDA receptor is one of those critical things. Lots of experiments will look at, they'll use an NMDA receptor blocker and see, okay, can you block the effects of whatever we're testing? And, if it's working through LTP by blocking the NMDA receptor, and that only shows if it's necessary. There's quite a few things that are necessary, but there's not very much. There's only like 3 molecules that are sufficient to increase it. NMDA is one of those. And we use these terms like necessary and sufficient. Necessary, of course, means that it's required. And I'll use the analogy sometimes, like to become a psychiatrist, it's necessary to go to grade school, but it's not sufficient to become a psychiatrist. You're not a psychiatrist at the end of grade school, right? But a psychiatry, in college similarly, but a psychiatry residency, even medical school is necessary but not sufficient. But a psychiatry residency is both necessary and sufficient. So that really gives you an insight into, okay, this is how you become a psychiatrist, psychiatry residency. So similarly, how do you induce synaptic plasticity? Both LTP and LTD both depend on NMDA receptor, and NMDA receptor is sufficient for both as well. So that was the idea with testing that. And we found that in a motor physiology experiment that we could enhance the effects. So it did show that kind of very specific data that you could enhance, or that I should say that the NMDA receptor was sufficient to increase the motor plasticity. And we found a few other things as well that have other LTP kind of properties to them. And then really importantly, Alex McGurr at the University of Calgary, I don't know if you've met with him yet, but I'd recommend meeting with him for sure. So he did the first clinical trial taking this same approach using D-cycloserine, and found that clinical effects were dramatically improved. You're comparing standard of care TMS, intermittent theta burst, 600 pulse, and 2 to 3-fold remission and response rates, markedly decreased symptoms, and then found the same thing with OCD as well. And, suggesting that it's transdiagnostic. It's, in other words, it's not just making up for a plasticity deficit or for NMDA receptor deficit or something that's specific to depression, major depressive disorder, but seems to be more specific to enhancing TMS effects. So that's kind of a more concrete and a more like, I talked about how it helps with counseling with patients for me to, include synaptic plasticity and understanding like why things happen the way they do, both maladaptively and adaptively. And in a more concrete way, we've been able to leverage this to improve TMS function and TMS efficacy and how well it works. And so, we've seen it replicate a number of times in our lab, doing a few different things, different kinds of protocols with D-cycloserine. And now we're looking at accelerated protocols with it. And it actually highlights something that I think is pretty important as well, which is TMS parameter space. Overall, the goal of our lab is to learn and understand how TMS works, and then apply that to pharmacologic augmentation and to parameter space. And I think, and I'm learning more that they also sort of interact with each other. We don't really see a big difference clinically between 600 and 1800 pulses of ITBS, for example. People have tested that, either formally or informally, both with accelerated and daily protocols. And it doesn't seem to make a huge difference. Downer and kind of the recent case series that they have, with really compelling results, just really strong response and remission rates, adding D-cycloserine and plus or minus Vyvanse with ITBS in 20 sessions in a day, and saw these really strong results. Well, we were first interested in understanding better the SAINT protocol and that mechanism of action. And so we did just 1 day of 1800 pulses a day, 10 times in a day. So just like the same protocol, we weren't focused on the network stuff or the targeting as much. Wanted to look at like the local plasticity. And interesting, we did see improvements, like a modest, 20% or so improvement in clinical responses a week out. And we didn't go out further, like like Jonathan had, up to 3 months or 6 weeks even. But we didn't see any difference with the D-cycloserine versus placebo. So we actually did a randomized controlled trial, and this is data that we're submitting hopefully this week. It's, we've been working on that. It's one of those things just keeps taking forever to get it out. But that's something that, we had a number of participants that had gone through, and we had talked to Jonathan back when he was conceptualizing the protocol that he was interested in trying to implement clinically. And then in turn, what he found there has inspired kind of our next phase of research, where we're looking at the same thing and comparing DLPFC and precuneus targets. Precuneus is another story that I can talk to you about if you want, but we have some reason to think that might be pretty helpful. There's so much going on. Like when you started off, and it's just a wild time in the field right now, both for really sad reasons, tragic reasons, like Nolan. But things are changing so rapidly, and we're learning a lot. And there's been some recent breakthroughs. It feels like that things are just kind of I could see the field being quite different in the next 5 years.
Yeah, well said. Look, it's a great understanding of how neuroplasticity can impact our care, and we don't know how to choose protocols and exact scheduling of patients at the moment. So you mentioned Jonathan Downer in his 1D trial, and he did sessions every 30 minutes, whereas the Saint does it every 1 hour. And classically, we've done one session per day for months on end. But one thing is that we tend to see, one thing Jonathan saw in his 1D trial is that the results of his TMS, of his ITBS plus D-cycloserine, were a little bit later, about the same time after that than if you did just a regular once per day. So how would you, if you were to help a clinician understand this and explain it to a patient, that TMS is working on a neuroplasticity basis, and what we're trying to do is stimulate neuroplasticity to help your brain in some way, and I'll let you describe what that is. And we're going to do it in this type of schedule and with this type of parameter, with this type of part of the brain. We're going to work on the left DLPFC or the right DLPFC rather than the motor cortex, because it's related to one of the depression networks. We're going to do it 12 times every half an hour, right? 12 times a day every half an hour, or we're going to do it once a day for 5 weeks. How would you help a clinician explain why we're doing these different parameters, when we choose the different parameters? Are we there yet in understanding which ones and when? And how can this help a patient understand that TMS isn't just a magic bullet that works straight away, right?
Yeah.
It's not something that you're just going to come in, get a session, and suddenly feel better. Help us talk through that understanding for a patient.
Yeah, it's a good question. First to answer, do we understand the best way? Definitely not. Like there's so much work to be done there and a lot of low-hanging fruit. So, a lot of impactful studies, I think, yet to come out. But we are learning things, and we are also inferring things from other, elements and trying to incorporate these. So I think that I think the learning curve will be exponential because we have more to build on than ever before. And we're standing on the shoulders of those that have come before us. I remember Nolan having we were having a conversation, and as I was kind of coming out of residency into the field, and he's talking about how he was able to stand on the shoulders of those that came before him and able to elevate the field. And that's kind of where all of us are at now, is we're able to additionally stand on Nolan's shoulders and the things that he had done, and one of the, Nolan kind of took this idea of being able to, there was a lot of safety concerns with TMS initially. And so really pushing, we don't know the upper end of that LD50 curve. And by pushing that, it kind of opened the door for everyone to be like, okay, we can actually give a lot more stimulation. And it appears to be quite safe still. So we don't quite know if we're at the upper plateau of that or not yet. And then to the part of your question about how to talk to patients. So the things you were describing, it reminds me of actually a conversation that I have most of the time with patients. That's kind of the main thing that I do clinically. I direct our clinic at McLean and see folks there. I'm always trying to kind of explain and educate so that they have an understanding of what what we're trying to do. You mentioned that it's not a magic bullet. We always, of course, spell out this is not a cure. This is a treatment tool. And the way that I describe this, and synaptic plasticity has a lot to do with it, is that, explain that there's networks in the brain that are, can be over or underactive, that are basically not functioning as they should be, or as we would want them to be in optimal health. And, in terms of where we stimulate, one of the reasons that what I describe, what we target, the left dorsolateral prefrontal cortex, in most cases, although this is, also kind of expanding as well. There's, a number of potentially new targets that might be better for certain components or certain aspects. And all of them, in theory, have the same common element, which is that it's like a node of multiple networks coming together. One of the things that I think justifiably raises suspicion about TMS to people, especially outside the field, is how does the left DLPFC seem to treat everything? And one of the reasons for that is because it is so connected. It's like the um, uh, the central train station or something where everything kind of goes through it. And so by, either enhancing the efficiency of it there or clogging it up, like either way, it's going to have a big impact on things far and wide, throughout the brain in this case. And so that's, I explained that's why we choose to target this region, because of its high connectivity to important networks that are involved in depression and in healthy mood. And then the synaptic plasticity part comes in because, it's of course not just one pulse. We're giving many pulses. And when we repeatedly activate something, it is engaging these mechanisms where the brain is learning, okay, this is an important pathway, and it's going to increase receptor levels there. That leads to more efficiency, so that when you have a synaptic event, it responds more easily than it would previously. And when that's the case, it's able to essentially complete that circuit or propagate that thought pattern or emotional memory or whatever it may be. The same kinds of things, I think of it very similar to something like cognitive behavioral therapy. It's just that cognitive behavioral therapy is I think it's more precise but less robust. But it's the same idea as you're focusing more on like fine tuning, like which exact circuit, but you have to keep doing it, repeatedly over and over. It takes a little bit longer. It's a little bit more slow, where TMS is a little bit more, you're hitting tons of like big swaths of tissue. And in all of that, you're hitting the kind of the important pathways that are involved in this. So it's, there's a lot of good analogies, whether it's, repeatedly like lifting a muscle or, uh,
And like that learning progress that you were talking about, that Nolan used in his analogies of using flashcards and repeatedly learning something every hour. So in the same way, would you say that with TMS, we're repeatedly doing this to improve that neuroplastic process in the area? And is that a similar thing with, for example, a 10 hertz protocol, an ITBS protocol, a 1 hertz protocol on the right side? There aren't any clear decision rules in the field that after X amount of sessions, we change protocol or we do that. And it's a little bit of trial and error, because on an individual level, we have a patient who may not be responding. If they respond, great, we stay now, right? If they're not responding, we tend to try and maybe do the right side, one hertz protocol, or we'll do an accelerated protocol. How would you, is that something that we're beginning to understand more about, or you could give any advice on in terms of neuroplastic effect?
Yeah, it's a really great question. And, unfortunately, I don't feel like I have a great answer as to how to make clinical decisions about switching protocols, switching targets. This is something that we discuss quite a bit in our own TMS rounds. And we also have these sort of traditional ways of thinking of high frequency left or ITBS left and CTBS low frequency right. And, it's like there's some kind of increasing evidence that may not actually be as important as we thought either. And that's not just in depression, but like in PTSD and other things. And so I think we have quite a bit still to learn about what happens with this. There's some evidence that both in animal and then we kind of see it in human, where it may just be that repeatedly disturbing what is otherwise kind of a rut or something, right? Like a maladaptive process, that it kind of can normalize, whether it's low frequency or high frequency. I think that we tend to see, if we're focusing in on, part of the reason that we have these old terms like inhibitory and excitatory for various protocols, I think we've largely moved away for that because it's not a one size fits all. Not only is there inter-individual variability, which is certainly the case, maybe, 60, 70% of people might have an excitatory motor physiology response to ITBS or 10 hertz or something. But the others don't. But then you also have the fact that you change some other component of it, like you double the pulse number, or you change the intervals or something like that. Like, one simple example is a well-known paper by Gamboa, Walter Paul's group, I believe, that doubled the ITBS pulse number and flipped the kind of potentiation of the 600 protocol, and with 1200 pulses, it was inhibitory. And so it's still ITBS, but it's depending on how you use it, and even the brain state that you're using it in, that can change whether it's inhibitory or excitatory. So that's why we don't use that term or those terms anymore, because unless you kind of show, if you do an experiment and you show it's an excitatory thing, then you would say it, right? But otherwise, there's too many other factors involved if you haven't actually shown it to say it that way. And so, what does that mean for clinical application of the TMS protocol that we're using, and when do we change from one thing to another? We've looked at kind of doing some randomized things ourselves, like at 15 sessions or even 20 sessions, having one group where we keep it, one group where we switch it, just as a matter of course. It's just so challenging, right? Because of the kind of, every individual is different, and it feels like one of those areas where it's going to be difficult to actually see a signal come out of there. And you wonder, okay, if you switch someone and they didn't get better, it's like, what if we kept them there and just kept giving, pulse, kept giving sessions, maybe we get there. Or if you switch them and they got better, it's like, well, was it just getting more sessions that got them better, or was it the switch? So it's really difficult to know on even if you did the same person a year later or something like that, it's still a different circumstance in life. There's things going on at home or not. And it's just like a really challenging thing to really parse out. I think more work in animals could be maybe a little bit guiding and helpful. And we're actually working on some things also with computational modeling that might be able to provide some insight into the parameter space. I think it's a really, like I mentioned, it's kind of one of the two main applications of what we're trying to do in our lab, and the augmentation and the parameter space. And so, I think it's really important, but there's some parameters that don't seem to be that important, and some that probably are and do seem to be pretty important. And then if we're changing the brain state with something like decycloserine, that also seems to change it further, like I mentioned with the 18 versus 600 pulses. And so hopefully we'll be able to kind of clarify that point a little bit soon. But yeah, this is one of those things that is really challenging to sort out. And I should mention that so as a field, we know that we know that there's an infinite parameter space. We know that some of these probably matter a fair bit, and maybe it depends somewhat on the target, the disorder that we're trying to treat, et cetera. One of the I don't know if you're aware of it's a little over a year old now, the TMS journal, transcranial magnetic stimulation journal. We are forming a special issue where we will be focusing in on parameters. So specifically like head-to-head trials. We'll have a series of systematic reviews that go over each of these parameters. And within each of those, kind of expert opinion on interpreting what these trials tell us, and sort of what domain, what areas would be considered reasonable to try clinically or to use clinically. We already use a number of off-label things like 1 hertz, for example, and which things would be, maybe things that should only really be tried if we're going to really test them and inform patients we want to test this thing, right? And so we don't want to just give it to them as standard of care. We want to let them know that we don't know enough about this, and we want to know more, and that's why we're going to try it. We think it could be helpful. And so basically to kind of lay out a little bit more clearly to the field, because I feel like I'm in this field as much as anybody, and it's not clear to me either. Like it's, there's a lot of ambiguity, there's a lot of uncertainty, and there's a lot of things out there that, I'll encounter stuff and I'm like, how did I not know about that? And things that, I was talking to one of your one of your mates down there in the land down under, Robin Cash, and he's like, he did a randomized trial, control trial with like 4 different intertrain intervals. And he's like, why didn't anyone pick that up? Why don't clinicians use that? It's like, truth is, there's just things out there kind of floating around. And so I think if we're going to try to solve this space, we first need to identify what we have, and then we can kind of identify, okay, here's the next steps forward. So that's one of the things that I think is really important to me with the journal, to try to move the field forward.
Yeah. Thanks, Josh. It's clinicians are placed in a really difficult situation, I guess, with scheduling. They might have allocated from Medicare or insurance a certain number of sessions, and then they have to decide at which point they they pivot and they make a decision. And it's good to know that nobody has the answer, especially since there are so many inter-individual differences. One person might have different plasticity in their brain, and I found it really interesting to look at your research on athletes and musicians and the plasticity that they had and the outcomes you had there relative to the presumed extra plasticity that they had prior to TMS. Would you like to have just give us a quick hint about what that research told us
Yeah.
about neuroplasticity, but also where the field of TMS in performance is at this stage?
Yeah, I think that was the study on musicians and athletes was actually the idea of Jamie Kwan, who was a research assistant in my lab and just left to do an MD PhD. We had these experiments that we'd ran with folks, and this was a retrospective study where we wanted to look back and see, okay, of those that like use their hands, like pianist, violinist, or volleyball player kind of a thing, like, did they have any difference in plasticity among those that did not? And found that they had like a really clear increase relative to those that didn't have that. And so to me, that was really interesting, not just from a performance enhancement standpoint, because I actually don't think, it suggests that those that do something a lot have increased ability and plasticity to extend that. And it's not so surprising. Like we kind of see that with, someone that's really good at maybe one element, either a language or an instrument or a sport or something like that. Like they tend to be able to pick up other things better because that part of their brain that's doing that, they've increased the potential for plasticity. And it's likely, I'd looked into this, it's likely they have more NMDA receptors that are able to respond to a signal and a stimulus and induce that plasticity. So that's what we found with them. And what I, speculate about is that people that have gotten really good with therapy, really good with mindfulness, CBT, whatever, like they've kind of trained their brains to sort of think a certain way. And then when we stimulate with TMS, does this enhance that capacity to respond? So that's still an unanswered question ultimately, but it's, it's one of the things that made me excited to look at that. So anyway, I thought it was a really, interesting result that came from Jamie's study.
Yeah, great. And look, you mentioned brain state, and I talk a lot to clinicians when I'm teaching TMS about current brain state and trying to keep your patient activated during TMS. And also, does a lot of mental health patients, I guess, are in a rut, in the term that you used before, and potentially not as activated and potentially not stimulating that plasticity before TMS. So we talk a lot about conducting psychotherapy during a TMS session. Potentially that activates brain state. Maybe it's not the exact CBT or what you're talking about that makes a difference. Maybe it's the overall activation of brain state that increases plasticity and the effect of TMS. There's still lots of unanswered questions there, of course. But what would you say about advice to give clinicians about way to increase plasticity the best during TMS, both within session and between session? What advice to give patients while they're doing a course of TMS?
The advice that I would give overall, so during session is a bit of a different answer than between session. I generally agree with the idea of engage. Like we don't have clear randomized evidence about this either. And that's one of those things that's like, we kind of all know it, but we haven't proven it. We haven't shown it. And so, I think it's very likely that engaging these networks that are involved with, positive thinking and so forth would be beneficial while delivering TMS. I think the thing that would, but again, that's hasn't, we really need to kind of demonstrate that and identify like, what kind of approach, what kind of protocol might be best. Like that's some of that low hanging fruit that is, would be really pretty easy to implement in almost any clinic, even in a randomized way. So, hopefully there will be more that will come out on that. Between sessions, I usually talk to people both during, at the beginning, during, and after a course of TMS, just about brain health. And I think that when we optimize the brain health, it would be similar to, if you're training for, I know that you were a Olympic athlete, right, Trevor?
Yes, that's
Um,
correct.
and so, it's like as an athlete, if you're malnourished, then it's going to be hard to really, no matter, even if you're trying to do the same workouts and the same training, it's not going to have the same effect on your body as if you're in a healthy state. So I focus on brain health and just kind of the basic things that we sort of all know, and none of it's really a big surprise, but can easily be forgotten or not thought about, especially for a patient that's already in a depressed state. So the things I usually focus on are sleep, diet, exercise, both cardiovascular and strength training, because they both have independent evidence that that's helpful, and then social and cognitive engagement. And so trying to do those things during, while people are not getting the TMS, I think is what is most likely to be helpful. So just providing the right environment for the TMS to have its effect. Otherwise, it might be like, trying to do the really intense training in a malnourished Olympic athlete.
Yeah. And you touched on sleep there, Josh. So that you have done a couple of papers on sleep, I believe, and how it affects TMS outcomes. The treatment of insomnia during TMS, you found that to be pretty important, I believe.
Yeah, yeah. Actually, that was another idea from Jamie Kwan, who had done those things. So we looked at just our naturalistic clinic cohort, and of course, we know that insomnia is a big part of depression. So we needed to separate out insomnia from depression and see, okay, how do depression scores compare to insomnia scores, and they really kind of travel together. Um, the thing that was kind of interesting that jumped out from that, and the thing that I think would be a take home point for clinicians, is that if you looked at insomnia and like non-insomnia people and insomnia people, and then you broke both of those up into took meds for sleep and didn't take meds for sleep, the only group that didn't really have the same trajectory of recovery and they did worse, was the group that was insomnia and that did not get meds for sleep. So basically, even if someone has insomnia and they're not getting great sleep, but if they're getting meds for it, and this is not just the sleep scores, it's actually separating out the sleep scores, just the depression minus sleep scores, they get better if they're taking meds for sleep, but not if they're not. And so, I highlighted in my mind the importance of, in my mind, it probably has to do with the brain health idea of being able to uh, have the optimal environment, and we know how important sleep is for consolidation of memory. And again, I think these are the same thing. Like learning and memory is the same process at the cellular level as synaptic plasticity is. And so whether we're inducing it through TMS or we're inducing it through, therapy, CBT, it would be, as an example of therapy, it would be, important in that way.
And of course, that's the variable you used in the study about taking meds for sleep. That's not the only way we can improve sleep as well. Medication's a large portion of that. But CBT for insomnia and sleep education is extremely important. A sleep medication can be very good temporarily and potentially damaging long term as well. So there's a large interplay of sleep intervention if that is an issue for the patient, of
Yeah.
course.
And that was not like an intervention study. It was just naturalistic. And so it's like, okay, here's some factors that we have available to us that we can look at. And I agree about CBTI, and I feel the same way ever since residency. It's like every so often I'll just have like a night of crappy sleep. And I think that seems like everyone that kind of went through a neurology residency kind of feels the same way. But if, you know, I think it's ideal if we can use behavioral therapies like CBTI in lieu of medications. So, but I do think it's quite underutilized. It seems like a very small minority of patients that we have, and part of that is access. There's not a lot of therapists that are trained in that, and it's difficult to get access to them in the first place. So maybe there will be, methods with sort of artificial intelligence or, some sort of scalable way that people can kind of get access to that information. I don't know if it would be as effective or not without another human being to be accountable to and to, other people to kind of work with along in the process. But yeah, important.
Very important. And we spend a large portion of our training time with our staff members and other clinicians that we teach on sleep and the importance of it. So last question, you've been very generous with your time, Josh. Thanks very much. I'm just sort of pivoting a little bit away from what we've been talking about, but I found this very interesting. Everybody in my courses ask about coil orientation. And when you're placing the TMS coil on the DLPFC, on the frontal lobe, that 45-degree angle, is it important? What is it doing? Is it related to the way that it was first described over the motor cortex? Is it the same issue between DLPFC and the motor cortex? And in that article, you mentioned, in fact, changing the orientation may, in fact, give access to different networks like the frontal parietal network or the default mode network. Can you elaborate on the importance of coil orientation for us?
Yeah. Core orientation is it's a tricky one because we know it's important, but we don't quite know how to best implement it. And I'll explain that. So we know it's important because, even doing motor physiology experiments ourselves, will, be getting some pulses like this, and then we'll switch it 30 degrees, and the amplitudes of the motor evoked potentials will be 3 times what they were just by that rotation. And actually, we had a journal club today in our lab on article from Andres Vlachos's group, and they actually in slices, hippocampal slices, they changed the orientation of their coil 90 degrees, and they were looking at CFOS expression, just like neuronal activity expression, and they had this large increase in the normal paradigm they had, and then they switched it, and it totally lost it, abolished it. And so, both animal and human, we know that has a big effect, and that's kind of what the review that was actually led by a couple of your nearby colleagues in Melbourne, Leo Chen and his postdoc Andres Cernas wrote that or led that article. We kind of it's that article identifies the importance of it in a number of different ways, but how to get the right angle is going to depend on the brain morphology of each individual. So, we tend to have this 45 degrees because we have a fairly consistent motor strip in the way that this comes down. And so, we want to you can kind of get the best activation by kind of hitting perpendicular the axonal fibers and a gyral crown. So the reason, we move that forward because that's what we had here. And so we're just moving it forward, but it doesn't necessarily mean that that's the best thing or that's going to get the biggest activation when we're in the DLPFC, because it's this in the prefrontal cortex, it's much more multi-directional, we'll say. So, that's one of the things that when we do structural targeting in our research, we don't really use that clinically much, though some do. We will identify the location, and then we'll look at the gyral crown and we'll basically go perpendicular to it. So we will adjust the coil in that way. But, for scout-based targeting, of course, that's not possible. And even we do some functional connectivity guided targeting as well in our accelerated patients. And that's not a part of the protocol. That's not a part of what's done. And so this is, again, I think we see a common theme here where we have some ideas of some things that are probably and seem pretty convincingly to be important, but we don't yet have like a clear established way to do that. I would contend that it's, using scout-based targeting, it'll never be possible to know what someone's, because it's like, you could be here and it's going to go one way, and you could move forward a half a centimeter and it's going to be a totally different direction, because we've seen in brain anatomy. But if we are able to access, imaging guided targeting, whether it's structural or functional or whatever, that could potentially provide some insight in the future. And ultimately, like at least in depression, we do have some evidence from other other conditions, but I think that we could use a randomized controlled trial to sort of demonstrate this is the clinical response with this, and this is with the clinical response without it. Because ultimately, with all of these parameters and so forth, some of them seem convincing, and then when it gets to the clinic, it doesn't actually seem to make a difference. We had another RA of ours, Meg Vigney, had led this kind of exploration of caffeine. You asked about that before. Uh, Kind of the same retrospective analysis, post hoc analysis of our motor potential studies. Caffeine use blunted plasticity. And we thought, okay, well, if TMS works through plasticity, then maybe caffeine use will blunt TMS clinical responses. And we actually just today or yesterday, I think it was finally published, a clinical where we just asked folks clinically what they were using. Doesn't make any difference. So they did exactly the same inpatient, outpatient, no matter what. There's a lot of things we see that don't translate to clinical difference. There's only been a couple things that it seems, that seem to actually translate over. Decycloserine is one of those. Session number is one of those. So those are some of the things that I think we see that are pretty clearly and consistently showing their effect.
Yeah, you mentioned the parameters that are clearly showing the effect, and also the dosage of number of pulses per session seems to not make too much difference. There seems to be a large variability of number of pulses in a session, and that all turns out to be as clinically effective. But
True.
look, we won't go into that. Maybe to conclude now, Josh, I know I'll let you go after all this time. You've been very, very generous with all your information for us. Thank you. What should clinicians know about the working mechanisms of TMS before using it? If they're starting out with TMS, how can they describe what TMS is doing when they're describing it for a patient? How do you teach that?
Yeah, I mean that's a very important fundamental question. Obviously, I think one of the first things that everyone learns is that it works through producing magnetic waves, right? By this sort of time locked electrical pulse of the coil, we get these time varying magnetic waves, and these magnetic waves activate primarily axons, but neurons that cause firing. And when we repeatedly fire neurons, it tends to create a difference or a change in the strength. And depending on the pattern and the frequency, that can potentially push things lower towards an LTD like effect or higher towards an LTP like effect. We see LTD like and LTP like because we're not actually, that's LTP is really like a basic animal experiment phenomenon. And so, but it's a similar kind of effect. And so we recognize that it's inducing these kinds of effects in important networks that are involved in depression or involved in OCD or that are involved in pain modulation or whatever other indication we're trying to treat. And we don't know all of the optimal ways. Like we're trying to work towards optimizing how we deliver TMS and to who we deliver it to. But I think that it's important to understand from a plasticity standpoint that it's in the process of delivering these repeated pulses, this changes the strength of the synaptic connections. And when the synaptic connection or the synapse is strengthened, it becomes, whether it's the receptor numbers that are increased, and so it's more sensitive to a presynaptic release, or there's more neurotransmitter being released presynaptically, whichever side of the coin you're looking at, it makes it so that these function either more efficiently or less efficiently, moving that towards what is healthy for that brain circuit. And so we're essentially trying to use plasticity to bring the brain back into its proper balance and into health.
Right, which then flows on to a behavioral change. So we're talking about neuroplastic change from the TMS pulses leading on to more of a network change that helps our brain function in a more adaptive fashion that then leads on to behavioral change. And of course that process takes time. And that's why TMS isn't a magic bullet in one or two sessions. So we're trying to explain to clinicians and patients that this is the process that takes place, and it does take time, and that's why we need the commitment from patients over a longer period of time. So it's a different mechanism of action to medication.
Exactly. You hit it right on, which is that, the network level changes are what lead to behavioral changes. And it's underlying the network level changes, or the circuits being a part of those networks underlying those are the cellular changes. And it's activity at the synapse that really drives, if you look at the whole vertical column of neuroscience, it's the synaptic events that are driving DNA transcription, translation. And those don't just go diffusely everywhere. They go to where this activity is happening, which is strengthening these circuits, and those underlie these, circuit and network level changes. So we see it structurally and functionally as well. One thing that I think is like a useful analogy when we talk about mechanisms of TMS, there's two approaches or two ways to kind of think about, you could say, yeah, there is multiple mechanisms of TMS in the sense that you have things happening at a network level and you have things happening at a cellular synaptic level. But as we just discussed, those are really the same thing. It's just at a more, you're focusing in on the more microscopic kind of scale of things. And we talked about how, protocols like the same protocol and extended sessions, we didn't talk so much about that, but, giving more sessions, we know also increases the response. And so when we kind of talk about mechanisms, I have started thinking a lot about how it's like a car. And, if you ask like, how does a car work? If you're looking at it from the outside, you might be like, oh, well, a car works by the wheels. The wheels turn around and around and it drives the car forward, right? Or if you're looking at it from the inside, you might be like, oh, well, you push down on the gas pedal and that, that accelerator pedal makes the car go faster. And it's of course, when you actually kind of look in to the engine and you recognize, okay, this is the thing where if we took an old car from the earliest days that goes 10 miles an hour and we took one of our cars now, if we were to take, say, the wheels or the axle or something, and we put it on the old car, it probably wouldn't go very much faster, maybe a couple miles an hour or something different for being a little bit more efficient. But if we took one of our engines and put it in the old car, then it would go, 10 times what it's going. And so it's, that rate limiting step, that rate limiting mechanistic engine, that is the synaptic plasticity from the evidence that I have seen so far and that, that we've looked at. That's kind of the engine of what really drives and makes TMS effective as it is. And so it's important to deliver TMS where it needs to be delivered. Otherwise, it's like, you have to get to a destination, but you have no map and you don't know how to get there. It doesn't matter how good your car is, right? If you're going the wrong direction. And if you're in the right spot, but you're not giving an effective protocol, then it's like where you're getting, but you're having to push the car along. It's not going to get there very efficiently either. So I think there's good interplay between those and what we're trying to deliver to our patients.
Yeah, fantastic. So, look, we're definitely in a very, very interesting field, trying to discover all the different parameters of what will make TMS more effective, not only at group level, but on an individual level, which is even harder. And if we can understand some of those basic mechanisms at the neuroplastic level, well, then we can really change that engine, as you're saying. So thanks for that analogy. That's great. And just very, very last thing, any exciting things that you're working on to, in the field of TMS, it's constantly evolving, things we don't even know about pop up, like you said. What's exciting you at the moment in your research and in the field, Josh?
I alluded briefly, the thing that I think I'm feeling pretty excited about right now is, we're looking into these 1-day protocols. So sort of building off of the work that we did previously with kind of the 1800 pulse 10 session and Jonathan Downer's clinical work and implementing these 20 session a day protocols. So we're testing that in the precuneus and the dorsolateral prefrontal cortex and, seeing some really interesting results from that so far. And so very excited to, have that. That's a randomized control study that we're doing with that. And we have neurophysiology markers with TMS evoked potentials and motor evoked potentials and, multiple imaging scans before and after and so forth. Hopefully we'll not only kind of get a good sense of what the clinical result is, but we'll also understand a bit about how it's happening. Which is one of the things that is missing is we might have a really great clinical trial, but we don't get, don't have the mechanistic things going on with it. And, or we have just a single session neurophysiology protocol, but we're not really getting like what the clinical connection is. So we're hoping to be able to kind of, bridge those two. And then there's a lot of other, one of the other things that we're getting started up right now is an R1 that's focused on mechanisms of continuous theta burst. So, does this work through long-term depression, or does this work through GABAergic mechanisms? And, as a field, we know much, much more about ITDS and high frequency protocols, much less about these. And they can be quite useful for a number of things, whether it's like decreasing rumination or anxiety or traumatic memories or epileptic focus or, various things. And so excited to get some more on that as well. But yeah, looking forward to, in 6 months to 9 months time, being able to have kind of a whole new set of things that we can talk about as we're going around. And it's a very exciting time in the field. It's such a great field to be in because we learn so much about the brain, neuroscience, but we also have this most powerful and effective tool. And I think that we honestly are really close, like right around the corner to being the gold standard in, efficacy, efficacy for depression. Depression, I see as sort of the poster child, the model on which we can build, in which we've learned a lot that we can then implement in other disorders as well. I'm excited to see the field in even 1 or 2 years, especially 5 years, 10 years. I think that we'll really see a ton of growth. And as we get much more effective, such as through, decycloserine augmentation, for example, how well will this apply to other disorders? And suddenly we have the efficacy that we need to push things through and get regulatory body approval and so forth.
Fantastic. And you mentioned the 6 or 9 months, you might have some further information for us. You're welcome back anytime. We'll have a chat here and chew the fat, Josh, about what you've accomplished. Yeah, it's been a real pleasure. Been a real pleasure to have you, Josh. It's been great to chat with you. So thank you very much for your time.
Thank you for the time, Trevor. Really appreciate it. Honored to be here.
Great. Thanks, Josh. Bye.
Thanks for listening. We hope you got something out of this conversation, and maybe it sparked an interest in developing your skills as a therapist. If you're interested in taking the next step, head to lms.neurocaregroup.com to access a range of professional online training courses in neuromodulation techniques such as TMS, TDCS, and neurofeedback. If you're looking for where to access these therapies, head to neurocaregroup.com to find our network of clinics throughout the world. We'll put these links in the description below. You might also be interested in listening to our other conversations I've had in the series. Be sure to follow our channels on YouTube, Spotify, or however you subscribe to your podcasts and listen to other conversations I've had with a range of experts in the field.